And welcome to the Dr. Bob Show. Almost everybody has had a common cold, but sometimes that leaves you with a sinus infection, pressure, fullness. Everybody's had that also. We'll be spending most of this show talking about sinus infections, what happens when they don't go away, what's the treatment, and what can we do about it. My guest is Dr. Mark Overholt. Dr. Mark Overholt is a board-certified ear, nose, and throat specialist, and he'll be giving us that information. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about GERD, reflux disease, how it can cause other medical problems, and lupus. What is lupus? How do I know if I've got lupus? And did you know there's new treatment for lupus? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Mark Overholt, board-certified ear, nose, and throat surgeon. We're going to be spending most of the show talking about the treatment of sinusitis, and I want to evolve into the newer surgical treatments when somebody doesn't respond. Mark, welcome to the Dr. Bob Show.
Nice to be back.
How common is sinus infection?
Extremely common. In fact, about 30 million people a year have sinusitis in our country.
So almost everybody gets a sinus infection at some time. You get a common cold, goes into the sinuses. Most of them get well by themselves?
Most acute bouts of rhinosinusitis resolve by themselves.
Now you say rhinosinusitis. What do you mean by that?
So on TV we see sinusitis, but in medicine we talk about the combination of nasal or sinus infections. You know, the sinuses and the nose are actually separate. The sinuses drain into the nose, if you will. And a lot of nasal infections or illnesses actually lead to secondary sinus infections. And so we group them together, nasal infection and sinus infections, and we call it rhinosinusitis, okay. Rhinonasal sinusitis.
Now, if it's acute, it's self-limited, that means it goes away on its own. What about chronic rhinosinusitis?
Now, they're different entities totally. Acute rhinosinusitis is typically a viral or bacterial infection, and most of those go away on their own. Sometimes you require an antibiotic if it's bacterial, but most of those are resolved fairly quickly. That's what the common person has. Now, chronic sinus disease is a total different entity, totally. Those people tend to have some sort of immunologic problem that leads them to have swelling in the nose, blockage of the sinus passageways, and secondary infections. So people who have allergy, some people have actual immunologic problems, immunodeficiencies, people who have conditions like leukemia or lymphoma or on chemotherapy agents or diabetes, or those people that tend to have immune systems that are less than robust tend to be predisposed to have chronic sinus infections.
Now, on healthy sinuses, there are holes in the head. They drain into the nose, you said. So do they communicate with the outside? Do they have air in them?
Yeah, typically we have paired sinuses in our head. We have two maxillaries in the cheeks, two ethmoids between the eyes, two frontals over the brow, and then back in the very center of the head is what are called sphenoid sinuses. And they're air-filled chambers. We don't really know why they're there. We think they lighten our head so we don't have a real heavy head to carry around with us. They may add resonance to our voice, but they tend to be a place where Americans suffer.
So they drain into the nose.
That's correct.
And if they get blocked, what keeps the drainage from popping through? What happens inside the sinuses to the cilia?
Yeah, so there are little sweepers that live inside the sinus lining that are called cilia, and they push debris and bacteria and infection and mucus towards a common opening. They actually have directional propulsion, if you will, and as they push things toward that opening, they clean us all the time. Well, if there is swelling in the opening, the little neck that may drain the sinus, and that area becomes obstructed, the cilia can't push the material out. And then we're at a place where we're at risk for infection. What tends to happen is we tend to reabsorb the gas in the sinus cavity. We tend to get low oxygen tension. The lining gets sick. The bacteria that may be there now have an opportune moment to sneak in, wreak havoc, cause an infection, and that actually kills the cilia. And so over time, the cilia don't work. And even if the openings regenerate or the swelling goes away so that we can ventilate that little plumbing channel, if you will, A lot of times we don't clean our sinuses the way we did before we had those chronic recurring injurious infections.
So if somebody has a chronic sinus infection, they've tried all sorts of medicines, they've gotten rid of their allergies, there's no polyps, they've got their nose straightened out, they've gotten rid of all the disease inside the nose, and they're going to need surgery. Back in the 70s, I want to start the show talking about how surgery has advanced over the years. They used to do what we call windows. What's a window and how is that performed?
Windows are an old surgery that some probably still perform, but not very many. In the nose, in the floor of the nostril, old-timer ENT guys used to think gravity is the way things drain. We didn't know much about cilia pushing the debris towards a higher opening, and so the thought was, let's get a big opening at the bottom, just like you would in a drain, and that'll allow the sinuses to evacuate the fluid. And so they would make old openings in the floor of the sinuses, and that was, with less modern technology, and lots of people have fear about that because it was chisels and hammers and nasal packing and some short-term misery associated with it.
So you put in a window this way, but the drainage hole, which is up this way, wasn't opened. And so you've got a new opening. Was it effective? Did it work? Did you find out that it wasn't as good as you wanted it to be?
It worked, but it's not as good as you wanted it to be. I think that's the way to categorize it. Certainly some people were better because you had a vent. You never were completely obstructed, but it did not return the sinus to its normal function the way it was intended to work. And so people would still have ongoing difficulty because of that. And over time, with studies, we began to recognize the function of cilia, and the shift went from nasal antral windows down low in the nostril to surgery in what we call the middle meatal area. And that's the business end of the nose where the cilia all push all the particulate and bacterial matter.
What's the osteomeatal unit? That's a name that we're going to be talking about a lot. What's the osteomeatal unit?
That's the tree trunk, if you will. All the little drainage pathways funnel down into one common channel of opening that evacuates the ethmoid and maxillary sinuses. The frontal sinuses will drain through the ethmoids, and so you can imagine if the ethmoids become affected and blocked, then the frontal sinuses may back up. But the osteomeatal unit is that common end of the line plumbing channel where you've got to have it open if you want everything behind it to work normally.
So what's a CT scan of the sinus like? This is a CT scanner. It's called a Zoran MiniCat. It's made specifically for sinus x-rays. It's got much less radiation than the conventional CT scanners, about the same amount of radiation as a chest x-ray. So let's see what it's like. I've asked Aida to come and situate me.
Okay, lean your head all the way back. I'm going to place 2 sponges on the side of your head and bring your chin down for me.
That's right. I always forget that.
I'm going to place 1 more strap across your forehead to reduce the motion.
So that keeps you stable. Now you're ready?
Yes.
It's going to take only 10 seconds. Let's see if that's right. And I'm supposed to be very still. That'll be hard for Dr. Bob. I didn't feel a thing, and the CT scan of the sinus has been done. Wait a second, let's go look and see what it looks like. So here we are. This is what a CT scan of the sinus looks like. Actually, the patient is looking at me. So this is the left side, this is the right side. When we see blackness, that's great, there's air in there. And on this sinus, it looks great. What we have to do is follow this little area right here. That's called the osteomeatal unit, and that's where all of the sinuses drain. Now, if this is blocked, we can do 2 things. The surgeon either removes this little area there, there's no packing, there's no bruising, there's no bleeding, and if he wants to, he can go do the balloon sinuplasty, where he puts a little balloon up in this area right there, inflates the balloon, it opens up the area, and then he deflates the balloon. It's left open. It's less invasive. That's called sinuplasty. Your surgeon will know exactly what procedure you need. So remember, the CT scan will give your doctor information that nothing else will. We're talking with Dr. Mark Overholt, board certified ear, nose, and throat surgeon. We've been talking about chronic sinus disease and how back in the old days, when Dr. Bob first started practice, they used to put a little hole into the sinuses through the nose, went right into the cheek, and they left what they call nasal antral windows. And we found out that gravity didn't make the sinuses drain. They needed to do something else, and now we're at functional endoscopic sinus surgery, FESS. What is that?
That's the evolution of sinus surgery. As we were talking earlier, as we began to recognize how the sinuses function, we started to focus our attack on the sinuses to try to return them back to the way they were before they were chronically infected. And so we talked a little bit about the osteomeatal complex, which is the natural opening of the sinus. And now surgery focuses on that unit, really. We try to look into the nose with a fiber optic telescope and open the natural sinus opening. And
is that easy to see?
It is with a telescope. It really is.
And you look, and you can find where you're wanting to do this. So what are you looking for? What's the uncinate bone?
The sinus cavity obviously has an opening into the nose, and you can consider that it's round. And there's a little bony shelf that sort of inserts on the front edge of that round window and goes backwards. So if you look at it from behind, you can see into the sinus cavity, but it blocks from the view from the front end. So when that little uncinate bone comes off, which is part of a traditional or of a functional endoscopic sinus surgery, then you have a nice wide open sinus passageway, and you can look right into the maxillary sinus and see what's going on. You establish drainage, ciliary function beats towards that opening, and the sinus cleans itself the way it's supposed to.
So that seems like no-brainer. That's what you want to do. You want to do that type of surgery so that you can restore function. What are the results like?
Excellent. I would say 95% of people who have sinus surgery get well. There are a handful of people that have immunologic problems or who make polyps, who continue to have some intermittent difficulty. I think you could consider that they will be better from the surgery, but maybe never fixed. They're the chronic sinus patients that are out there in this world. And we're getting smarter on what the reason for that is from an immunologic standpoint, and we're beginning to focus our thoughts on how do we address the immunology of sinus infections and why that person can't mount an immune response to fight off infection like they should. You would think you establish drainage, it's good, but it's not all plumbing. Plumbing is a lot of it, but it's not all plumbing. There's a lot that has to do with how each person can look at an infection or an inflammatory response and attack it.
In the old days, in the 1970s, when you did the windows, we packed the nose, and the nose had lots of bleeding. And when they pulled the packing out, and people said, I don't want any sinus surgery anymore. What's it like with the newer surgery? Do you have bleeding? Do you have packing? Do you have the miseries after the surgery?
Yeah, there's so much fear and misconception or misperception of what sinus surgery is because of those old days. Modern sinus surgeons typically don't pack the nose. There tends to be less bleeding. The lack of packing and the focus of surgery with our smaller tools allows us to be more precise. It causes less pain. In fact, most of my patients will say they had a little burning in their nose that may have lasted for an hour or two, but afterwards they felt little, if any, discomfort.
How much work do they have to miss?
I do plenty of operations on a Friday and have people go back on a Monday. I like people to consider having 3 to 5 days off from work, because I think it's good for their body to get a chance to recharge, but within a couple of days you probably can return to work.
Do you remove that uncinate bone that covers the opening of the sinus? Do you clip it off? How do you get rid of it?
We have a special tool that you and I have seen in the past on this show that's called a shaver. It's a long, hollow cannula instrument like a straw that has an open mouth on the end of it and a little internal oscillating blade. And it's like a Pac-Man tool, the old game we used to play, and it will sort of nip away the edges of that uncinate bone until it's gone. It's very precise. It's much more precise than the tools we've had in the past, and it has revolutionized sinus surgery.
Mark, I can look at the CT scans of the sinus and I can see the people who've had sinus surgery and how wonderful the drainage is. There's a new guy on the block in sinus surgery that we're hearing about. We know in the heart that we can put little balloon angioplasty and open up coronary arteries. Is there a type of plasty, balloon surgery we do in the sinuses now? I've heard about it.
Yeah, there is. It's a real hot topic right now, and one that I think stands to really help us in our armamentarium of tools that we have when we operate on people who have sinus problems. The balloon, I actually brought some devices that we'll look at in just a minute if you'd like to.
Sure.
But I think the balloons are fantastic. They're specifically good in people who have frontal sinus disease. That's an area where it was hard for us to get into in the past because it's so far up that our lights and our cameras don't allow us visual access as well as the places that are directly back in the nose. And so now we can put a balloon into the frontal sinus with a little light on the end of it. We can confirm that we're in the right spot, and we can dilate up the drainage pathway with that balloon and back out with minimal trauma.
Does it stay open?
That's the question. That's the million-dollar question. There are studies that show that balloon sinuplasty works out to 2 years, where people have been looked at to say, is the opening, the ostia, still there and patent and open at 2 years? And the answer is yes at 24 months. The question is, will it stay open? And we've done this experiment in cardiology, and in cardiology we began to realize that you have to put stents in some people because it will narrow over time. Sinus disease clearly is not as deadly as a coronary vessel closing down, and if somebody could have a little office-based procedure with a balloon that they wouldn't have any downtime from work, it would take them 20 or 30 minutes to do it, and they can get right back that same day, it may be perfect for them.
Let's look at your balloon. You brought a sample here. It's a sample. Let's see if we can show how we can do that on the show here. I've got a light here. It's nice and warm. Is it still working?
It's still on, yeah.
Okay, so there's a light at the end right there, the battery, and this is what? This is a syringe.
And it's filled with saline that will inflate the balloon on the end of this cannula. So this device gets inserted into the nose, and the tip will go into the sinus cavity of interest. This actually is bent to go in the maxillary sinus, so it has a little bit of a sharper bend. And as it's introduced into the maxillary sinus, then the balloon can be advanced over the catheter like that.
And then I squeeze, look at that. So it opens up. So it opens up then the sinus ostia that you're there to try and reestablish. How long do you leave it open?
5 or 10 seconds, and do it a couple of times. And this is a 7-millimeter balloon, so it will take an ostia that may be 1 millimeter almost blocked and dilate it up to 7 millimeters, which is a huge improvement.
When you withdraw, after you've dilated to 7 millimeters, will it stay at 7 millimeters or go down to 6 or 5 or 2 or 3 or 1?
That's the question. We know it stays open. There's not data to say 3, 5, and 7 millimeters, but the clinical improvement is obvious in patients that have frontal sinus disease, or this tool is excellent for patients, I think, who have recurring maxillary sinus infections, where when we do a CT scan, we may not see a lot of soft tissue swelling or evidence of a chronic infection like we do in our patients that have traditional functional endoscopic sinus surgery. But the patient can tell you, Doc, I'm sick all the time. I'm missing work, I'm requiring antibiotics on a regular basis, and every time I take an antibiotic, I get better. You and I get an x-ray, the x-ray looks normal. Well, this may be a great device for that person. Just to open up the ostia enough that they can't develop swelling that will occlude the sinus opening.
So this new guy on the block, is it going to be around here 5 years from now?
I think so. I think balloons are here to stay. The real challenge for us as physicians, every time a new surgical tool comes around, is to decide what is the appropriate place to utilize this, where does it best benefit our patients so that they get a long-term recovery and improvement with the minimum amount of invasiveness.
Mark Overholt, you keep us up to date here on the Dr. Bob Show. It's great. We've gone from windows to endoscopic sinus surgery to now sinuplasty. Thank you for coming and teaching.
It's nice to be here. Thank you.
You're going to want to stay tuned. Later on, we're going to be talking about what is lupus, how do you diagnose this, what are the symptoms, and how dangerous can GERD be if you don't treat it. I want to thank Dr. Mark Overholt. Excellent discussion on sinus surgery and what's new for you and me. And now for questions from you, the viewer, that I think will be important to your health. Question number one, it's a great question. My doctor says I have GERD, but I'm tired of medications. My next door neighbor said it'll be dangerous if you don't take those medicines. What are the dangers of GERD? Well, when we swallow food, it goes down into the stomach. When it's in the stomach, acid is produced to digest. If some of that acid comes back up into the esophagus, we call that esophageal reflux disease, and that's what GERD is. Now, it causes heartburn, a burning sensation in the middle of the chest, can be treated by certain types of eliminating fatty foods, foods with mint, chocolate, spicy foods. Losing weight will help. Don't eat big meals and then lay down and go to bed. Don't eat before you go to bed. And take medications. Medications such as the purple pill, Nexium, helps cut down the acid in the stomach so that the reflux doesn't come back up with acid in the esophagus. What are the dangers? If you don't treat it regular and you don't pay attention to GERD and you have heartburn all the time, it can damage the lining of the esophagus, which becomes precancerous. The reflux can also go up to the middle part of the esophagus, send a message to the lungs, and can make asthma worse. So if somebody's having asthma and their asthma is out of control, we have to think of reflux disease. The reflux can come all the way up into the throat, especially at nighttime when we're recumbent. It'll go back and it can burn the vocal cords, causing hoarseness in the morning, and actually may even go and burn the area where the sinuses drain into the nose. So don't treat your GERD, and you're looking for problems with sinus disease, with chronic hoarseness, with worsening of asthma, and maybe even cancer of the esophagus. Pay attention to your reflux. Pay attention to what your doctor says. Question number two, Dr. Bob, how do I know if I have lupus? Well, lupus is what we call an autoimmune illness. That's a big, long medical word, but simply means that the body begins to attack itself. And it will essentially attack by building antibodies against the kidney, against the muscles, against the heart, against the lungs. And so we have an autoimmune illness where the body attacks itself. When it attacks itself, it works through what we call the complement system to cause some damage to the kidneys and to the heart and to the lungs. Usually we become photosensitive. Light will hurt a rash. It's usually a butterfly rash. It's a rash that doesn't go away. And your doctor, if they see a butterfly rash, will think about lupus. There is a form that's just discoid lupus. It's just a rash of the skin that's there. But when we involve the other organs or muscles, we frequently have muscle aches, we have joint aches, we have low-grade fever. The doctor can't figure out what's going on, and they test for lupus. There are some excellent tests where we test autoantibodies against the nucleus. Every cell has a nucleus. It's against certain cells. The DNA that's in the cells, there's double stranding. If there are autoantibodies against the double stranding DNA, then that's part of verifying the diagnosis. There's no one specific test. There is a new medicine out, and that new medicine works against the autoantibodies of lupus. It's only indicated if medicines have not worked, and we've got medicines, anti-malarial medicines, we've got cortisone medicines, we've got methotrexate, some anti-leukemia medications. It's only when those have failed that the new anti-autoantibody, it's been pretty fancy, isn't it? It's only when everything else has failed that we use the new medicines. We're getting smarter. We're doing a better job. If you've got lupus, we can diagnose it. See your doctor, talk to your doctor about, you think I could have lupus? You'll get blood work. If you do, know there's a sequence of events, of medications, and a brand new medication that's been so helpful to some people with this chronic illness. Well, that's all the time that we have for this show. I hope you've enjoyed it like I have. I hope you've learned from this show. Remember, 4 things. We've got to be exercising. You've got to exercise every day. Have a fun time. Find somebody in the house and go out and walk with them. Find a next door neighbor, go out and walk with them. Find a friend, walk with them. Walk at lunchtime at work. Enjoy it. Enjoy that walk. Enjoy that exercise and make it 5, 6, 7 days a week. Eat properly. We've been marketed to enjoy food, and food sure does taste good. Be sure that you're eating the right kind of foods. And you know what they are. It's not the fried fatty foods. It's the foods that have been baked. Eat more fruits, more vegetables. You'll get healthier. You'll start losing the weight that you want. Get 8 hours of sleep. There's so many things that make us sleep deprived. Sometimes we just don't go to bed. But if aches and pains or snoring is keeping you awake, see your doctor. And most of all, we want that laughter in your life. Laugh a lot, and you'll stay healthy.